Assalamu alaikum. Good morning, everyone. We thank Mohammed Al-Itabi for delaying us. Okay, so we'll start this session with live case from Italy. I'm very honored to have an esteemed panelist. I have Abdurrahman Al-Mugheri, Mahmoud Turena, Salim Asiri, Abdullah Shahab, Mohammed Al-Mukhaini, Wael Bushoka, and Adel Riyami. And we have a great case from Italy, led by Dr. Luca Testa. So we are looking forward. Luca, sorry for the delay. We have somebody to blame here, but it's fine. So the mic is with you if you don't mind. We have a great case. Good morning, Italy. Buongiorno.
Good morning.
Come stare? Bene?
Bene. Thank you very much. Thank you very much.
Okay.
And it's my great pleasure to welcome you here in Cat Lab number 1 in Policlinico San Donato. Although it's a very bad rainy day, but I'm actually looking forward to the sunshine there in white. So it is my pleasure. Let me just introduce the team. Very close to me is Dr. Brambilla. She will help me to do this case throughout all the, let's say, explanation, technicalities. Also, we have a fantastic team today because we got 2 technicians. There is Valentina and Jessica, but also 2 nurses, Elisabetta and Pablo, and also the tech from the company. I'm not going to disclose which company because we'll discuss that later on. So welcome. It's our great pleasure to share some knowledge, some experience, some technicalities with you. So I'll now give the word to Dr. Brambilla because she will introduce the case, and then we stop to discuss possible strategies with you. Do you agree with this?
Sure. Go ahead and present
Good.
the case for us, please.
Good morning.
Yes.
So the first slide, please. So the case is the case of a 76-year-old woman, hypertensive smoker. In 2021, she had a syncope in moderate severe aortic stenosis. During this hospitalization, she was performed angiography that show epicardial coronary artery free of critical stenosis, anomalous origin of the left coronary from the right sinus with anomalous vessel running along the anterior interventricular sulcus. So the patient was symptomatic for exertional dyspnea, and in March 2024 was hospitalization for acute pulmonary edema. After clinical recovery, we scheduled elective study. So is a patient with a chronic obstruction pulmonary disease and mild renal failure. The echo show a preserved LV function and moderate mitral regurgitation. She takes conventional therapy with beta blocker, ACE inhibitor, and also inhalatory therapy. The next slide, please.
Next, please. Okay.
Okay. The STS risk was 6%, so is intermediate STS risk to be operative risk.
Next.
So we show a very calcified valve, aortic valve, with marked concentric wall hypertrophy and moderate aortic regurgitation.
Next.
Next, please. The gradient was mean was 48 millimeters mercury. Next, please. And you can see here the anomalous origin of the coronary artery. So this is a right coronary artery with the circ and also the vessel that is instead of the LID. This coronary take off in the near to the commissure between non-coronary sinus and right coronary sinus.
Next.
Next. The left is very small, is a left minimum only with one diagonal and one septal.
Next.
Next, please. So the pre-procedural CT show a perimeter 81 millimeter, so quite large valve.
Next.
Next, please. The principal vessel that take off in the coronary sinus, right sinus, is 22I. Next, please. And this is the cusp overlap and tricusp view that show a very horizontal aorta. Next, please. And we calculate a new commissural alignment view because we want to put the take off the anomalous coronary artery in the middle of the right coronary sinus. So we
Sorry, Nettie, let me just introduce this because this is really important because obviously this is a thing that we don't usually do. However, as a consequence of the really ectopic position of the single coronary artery here, actually Nettie evaluated the projection where we were sure not to interact with the ostium of this single coronary. In other words, this coronary arises from the commissure, which is typically not the case, because as you well know, typically the right coronary and also the left main, it comes from the middle of the cusp, not the commissure. So it's completely upside down. So in order to evaluate this, Nettie actually made this kind of reconstruction, and we'll discuss this further during the implantation. But this is really, let's say, a strange situation we need to evaluate with a CT scan. Sorry, Nettie, please go ahead.
The next slide. Thank you. So the pre-procedural CT show large tortuous and calcified arterial axis with the thrombus into the abdominal aorta. Next, please. And shows a relatively good right puncture site with a small spot of calcium in the wall of the artery, but not in anterior wall. Okay. Next, please. So
okay, thank you very much, Nettie. So, as we agreed before, now I think it's time to consider the options here. Of course, we got a plan, but I would like to know what is your plan actually?
Sure. I think we have a case of severe aortic stenosis with tortuous anatomy, horizontal aorta, and also the right system or right coronary system is the more important than the left, which usually you take care of. So my question to my dear panelists, I'll start with Abdurrahman. In this case, what kind of device would you use?
Usually in the horizontal aorta and severe angulation, we shy away from the self-expandable valve in general. But it can be done. Yes, it's challenging, but there is a role because the difference between the self-expandable and balloon expandable in general is the steerability and the deflection, just to align it. But with the advanced skills of the operators, probably is this overcome with time.
Mahmoud?
Yeah, I mean, I think this is a case where you could use everything. The valve is big, there's no LVOT calcium, the anatomy is good, so I think this is pretty open. Commissural alignment would be nice, but with very high coronaries, not a big deal. So I think you're good with pretty much any choice.
Salim, with the aneurysm and thrombotic there, what your precaution will be?
Well, I mean, to be honest, probably the valve itself is okay. Yeah, it's a horizontal aorta, but to deliver the valve to the heart is going to be the money here. I mean, it's very tortuous, aneurysmal aorta with clot there. I would use, a device where it has a delivery system that it's like slicky, easy to go through. I probably would go with Abbott Navitor, because it's really flexible. The NaviFlex, it will just, go easy. Hopefully, we don't need to, like if we have to put a bigger sheath to, go beyond the aneurysm and kind of protect us, the iliacs and the distal abdominal aorta, that would be great. But in fact, if you decide to do that, it's going to be a big sheath. So I would just go with the Navitor. It has the hydrophilic coating that it just, slicky, it go through. But maybe to add, a body wire in case if you find difficulties, like a Lunder gust or something, to put it in the ascending aorta to just, help you deliver the valve on Safari or Comfida wire. So that's my plan.
Abdullah, what's your?
Like looking at the axis, I think for me as is one of the major complications of TAVIs and others. I think to find a platform with the low profile and high flexibility, I think is my main approach.
Muhammad, regarding if you go with self-expandable valve, would you predilate in such anatomy?
I wouldn't think we need a predilate. Depends what platform you are using. We are using Navitor because with calcium you have a lower threshold to predilate. But we are using the FX system Volute. I wouldn't actually. The only concern with these horizontal aorta is that valve expulsion. So make sure what we are deploying that blood pressure is the patient is not hypertensive because the anesthetist might give medications when the patient drops the blood pressure, and there's the valve expulsion is high when the blood pressure is high. This is the second thing. The second thing is rapid pace. Pace them at around 120, 140. So at least for the valve to stabilize, because horizontal anatomy is very challenging. So you can use both, but as you take these precautions.
Wa'el, your strategy here?
Predilatation or?
Platform and predilation. If
Plat-
you go with self-expandable. Or
It should be a self-expandable. For me, in this case, the issue of the horizontal aorta is the main concern here, and the abnormal and the RCA. You need a sleeky and very flexible valve with and very stable deployment of the valve. And for the, I think in this case, if it's, the Navitor is very good, and also the Accurate Neo is really a good valve. And for the predilatation, unless you're using Accurate Neo for the Navitor or the Medtronic, I wouldn't predilate. There's not much calcium.
Adil, will you use a balloon expandable in this case?
The obvious answer is no, because I'm balloon expandable only so far. But I agree with Abdurrahman. My intuitive would be something that can flex in a horizontal aorta. So, Edward or my valve would be the choice to go for me. And I would not necessarily predilate.
Also, the system will be under tension, especially with all, let's say, the Pro Plus. Now, because it has two spines, and the moment you release, that tension is over, the valve will pop out. Now, with the FX system, which is only one spine, it's more flexible, so the tension of the system is less. Navitor has also that beauty of property. Thank you.
So, Luca, I think you heard all the panelists. The majority will go with
Yeah.
self-expandable.
And I have to say, thank you for your comments. Yeah, we'll go through this, not our strategy, but I want to thank you because all the points were honestly well taken. This is honestly the reason why we selected this page, because many points can be discussed, and obviously there's no single right answer or no single wrong answer. Nevertheless, we will show you what we have done, what we believe we should be doing. So next, please. That's our strategy. So the plan is to start with predilatation with a 24mm balloon, semi-compliant balloon, and then proceed with the Navitor Vision 29. The Navitor Vision has some specific details and features that maybe you are familiar with. But let me just go through in a minute about why we decided to use this platform. Next, please. First of all, tortuosity, the presence of thrombus, horizontal aorta, meaning that? We need something that is slippery, so it will go through easily, first. Second, we need something that is truly stable during the implantation. And this stability layer that's been introduced actually a few years ago actually made a lot of difference compared to the previous version. Third, we need to have an easy and controlled implantation. And it's well known, every time you start implanting this valve, there will not be a huge drop pressure, which is honestly something that you always see if you use a different platform. So next, there is this fabric cup that will actively seals against the challenging anatomies, like in this case. I mean, it is horizontal. And always, the problem with the horizontal is the movement, the shifting, and also the possibility to have a paravalvular leak, because you may end up with a platform that is not coaxial. And in that case, you can have a paravalvular leak. So having this fabric cup might be, we will see, might be a good idea. Next. Also, coronaries. As you were pointed out, the right coronary, which is honestly the system we need to take care of, is really high. Nevertheless, we need to think about the future. So, considering that at the moment we are just implanting the first case, but in the case there will be a problem over the next 7, 8, 10 years, no one knows, definitely having a cell that is 22 French will allow any possible second traveling tablet. Hopefully not, but we need to be prepared in terms of lifetime management. Next. Also, this vision Navitor is so particular because we have these markers. These markers, next, click, okay. So will allow us to have an idea or the precise depth of implantation. The target suggested by the company, but it's obviously a consequence of the presence of the conduction system, has to be 3 millimeters below the virtual buzzer ring. Next. And in terms of visibility, this is actually head-to-head comparison between Navitor Vision and Evolut FX. As you can see, the marker here is just below the commission. If you look at the Evolut, the marker is honestly on the frame, so it's slightly displaced. Next. And it's also much more darker, so it's much more visible. Next. The technique of implantation suggested is the cusp overlap technique. So we will start with a, let's say, gentle pre-dilatation. Next. Then we'll proceed higher in order to achieve the target. Next. And then at 8, next, sorry, we will confirm the implantation there, rotating the projection by optimizing the view and taking out the parallax. Next. This is what we believe we should be doing. Obviously, we are open to your comments.
Yeah, so thank you for presenting your strategy and also to show us the difference in the Navitor Vision, the new version compared to the previous one, and why you have selected this. And I think now we'll let you work. So can you...
Okay, let me start from what we have done already. So obviously we don't have time to discuss all the details in terms of femoral access and preparation, but let me just show that we are now using very traditional approach. And there is actually a reason. This is not our conventional strategy. We don't use 2 femoral arteries anymore. But in this specific case, the radial arteries in this lady are absolutely, dramatic. So we decided not to create spasm, to create a discomfort to this lady. And I have to say also, thanks to our anesthesiologist, Arianna, who is in the shadow. And when the anesthesiology is in the shadow, it means everything goes fine. We decided to have 2 axes, left and right. Please show the first one. Okay, so as you can see, we placed one catheter from the left one. We crossed over, so we placed a wire, a B18 wire, into the superficial right femoral artery. And then we evaluated the puncture site. From the CT scan, we knew that the bifurcation was relatively low. However, there was a little rock over there. So we actually optimized the puncture by using the echo as well. Next, as you can see here. And then we evaluated exactly the puncture site. From the vein, we also placed a wire in the RV in order to have a stable pacing in the case we need it. And as you well know, for an horizontal aorta, there might be the case of, let's say, relatively fast pacing in order to stabilize the system further. And then we placed 2 probe glides here in the right femoral, which is our strategy. We do that all the time. And then we actually proceed by placing the pigtail into the LV. And this is where we are now. So please, Valentina, show us. That's the angio. As you can see, this huge coronary artery is arising from the commissure. Well, let's say a big rock of calcium right in the middle, actually involving all the three cusps, but there is also at least moderate aortic regurgitation. Nevertheless, our strategy is to crack further that calcium in order to allow, let's say, a more stable implantation. So I have the pigtail inside, that's the situation. So if you don't mind, I will proceed by placing the Safari small wire, which is our workhorse, and then we'll go ahead. Please feel free to ask questions, to make comments, no problem, okay?
Sure, Abdurrahman.
Yes, because the coronaries came at the commissure. It's not at the.
Yeah.
So it makes the modifications of the commissure alignment. It's to be modified to the coronary anatomy, not to the sinuses or the cusp, the native cusp.
Exactly. Yeah. I mean, in other words, as you well know, typically, the right cusp, well, the right coronary and the left main are separated by an angle of 120 degrees in a normal anatomy, in a tricuspid configuration. But usually, for example, in a bicuspid, this angle is much wider. It's close to a flat angle, 180. And in this case, although it's a tricuspid, the two coronaries are basically placed very far away from each other. And the right coronary is basically placed at the commissure, which is really unusual. So we understood, and basically this work has been done by Nedi Brambilla here. I mean, she evaluated carefully the position of that coronary just to make sure not to interact that much. Again, I know that the height is 22. We all know that it's way away from the annulus. Nevertheless, having this information is important, especially to understand for the future degeneration rate and durability. That's what we are talking about. So let's go for pacing 180, please.
This size,
Okay.
size 24.
This is 24. Oh, not really. Okay, pace off, please. Pace off, please. Pace off. Just increase a little bit more. Okay, just increase. Now let it breathe for a second. Deflate, please. Okay. All right, so please, Nedi, you will inflate, I will keep the balloon in place. The horizontal aorta is also sometimes a matter of concern for the stability of the balloon. Let's go to 200, please. Okay, Nedi, go. All right, go. Okay, make it, all right.
More stable.
Pace off, please. Pace off. Okay, so as you've seen, we increased from 180 to 200 because the pressure didn't drop that much, so the stability of the balloon was not good, to be honest with you. Now, Nedi will remove balloon, and then we are ready for the valve. Are we ready? Okay. So let me just introduce the ABO team here.
Was there any thought about using a more stiff wire with the tortuosity? Safari is pretty
Well,
stiff.
it obviously is a good question. It's a good option, but using the Elanderquist is always, let's say, an option. But I don't really appreciate that much unless there is something that you cannot overcome by increasing the speed of the pacing. To be honest, as you've seen, we just asked for 200 and it was relatively stable. Let's see how it goes. There's always a compromise. Every technique, every step, has pros and cons. Using a Elanderquist is not our workhorse, as I said, but not because we don't like. But because honestly, we are very, very familiar with the Safari Small. I randomly, I would say, use the Safari Extra Small, which is, basically dedicated to very hypertrophic, small LV cavities. But, for a regular case, the Safari Small does the job very well. So that's the first challenge now.
And can you follow with the angio to show us how the flexibility and the pushability of this system as well?
Sure. Now we go to let's have a look at the abdominal aorta. Okay, I'm proceeding with, just stay there. Okay, no, stay there. Don't move. Okay, this is really, really smooth. As you can see, not pushing at all, just following, you see? And this is actually was what we were expecting from this device, to be honest, not because our friends from Abbott are here, but this is what we expect because the flex nav, it's really flexible. But it's not just a matter of being flexible and soft at the tip, but it's also a matter of being pushable. So it's not too soft like other, let's say, platforms. It is flexible. Now, Nedi will actually keep the wire in place by pulling gently. I will cross the aorta and I will show you live how it crosses. And as you can see, that is push with the wire, please. Push the, okay, that's perfect. And now, let's see how it goes. Okay, that's the angle we were basically, looking at. But I'm pushing a little bit. Okay.
Very nice and slick.
Yeah. I have to say that, I was expecting that, but you never know. It's good when you confirm something that you were expecting that is honestly happening. So let's take an angel. Please feel, yes. Okay, now let's take an angel. Okay, that's, well, relatively, this is not a precast view, right?
No.
Because as you can see, the precast are not in the same line, you see? So we need to go a bit more left, I guess.
Mohammed, you have a comment?
We are a bit off plane, as you can see.
I don't want to interfere at this moment of the procedure, but the question is for the second anticipated procedure in the future. Do you think that coming out of the issue of abnormal origin of the coronary and the issue of cusp or overlap or commissural alignment, why don't you use balloon expandable short frame? The whole thing is below the origin of the coronary, and it's no touch technique at the end of the day. I know that the femorals are a concern, but my first choice will be probably Edwards balloon expandable.
Well, let's say that, a balloon expandable, especially when you are in this situation, is an option, of course. It's an option. I mean, and I have to say there are only a few cases where you cannot use one platform or the other. But I think this is a case where you can honestly really select. And I believe that in 2024, the availability of multiple devices is a thing that we should always consider, especially in terms of the lifetime management. Having a large anatomy, I have to say, allows us to use almost everything. But nevertheless, some specific features should be actually driving the choice. And I have to say, even in 2024, the major source of complication comes from the access. So using a 14 French platform, I think is a good idea because you minimize the risk of having, let's say, problems here, which is again, honestly, the major problem, the major source of problems. In terms of paravalvular leak, there is always a compromise, but we start from a moderate aortic regurgitation. So I'm honestly not really worried about the possibility of having some kind of paravalvular leak. Of course, let's say that at the end. Okay? So if you don't mind, we start the implantation. This is the tricasp at the moment. Test, please. Okay. Let's start. You see that all the markers are actually at the virtual buzzer ring, meaning that we are starting in the position where we want to be. Now let's see how it will behave. Nedi is opening slowly and is working on the wire, of course, because there is always a matter of pushing and pulling just to make sure that we are stable. At the moment, we are not pacing because this lady is actually going at 100. So it's honestly, she's trying to help, and I appreciate it. A bit more? Okay. At some point, of course, we need to understand how much are we interacting with the conduction system. You all know that the conduction system is actually just below the non-coronary cusp. And the fact that we are opening now very close in this particular angle because it's horizontal, we are definitely interacting. But I have to say, everything is stable. Now we can proceed. Okay, I mean, it went down. Okay, what I will do, I will push on the wire and I pull a little bit. Okay. Now, well, I think we are not in a bad position now. Okay. Okay, we need to open. Pressure is
You want
going
to
down.
inject,
Open.
doctor?
Oh, not really,
Okay.
because pressure is going down. Let me open a little bit more,
Okay.
and I will do that for you. Just open. Okay, pressure is recovering. Okay.
And is it the same
Okay,
thing like
okay.
previous? You go up to 80%, that
Yeah. I mean, as I mentioned before, you always go to 80% and then you evaluate. I mean, of course, we need to give some time for the pressure to recover. So let's correct the parallax in order to have the 3 markers, not the one on the delivery system. This is crucial. As you can see, there are 4 markers, okay? We need to see the 3 markers on the skirt on one line, meaning that we are actually correcting the parallax. So let's see where we are. Just to remind you, the 3 markers are 3 millimeters above the edge of the cells, as you can see, and that's the target for us, okay? So please, Nedi, remove a little bit the wire, as they suggest, so we can centralize our prosthesis. Okay, pressure is under control. Let's have an angio. Can we, okay, please feel the repeater. Okay, let's take an angio. Okay, it looks, I mean, it is acceptable, but it is probably a bit high, you know? What I will do, I will try to centralize by applying a little pushing, just to see whether we can actually get 1 millimeter, as I think we've done, as you can see. Did you see that?
You want to
We
do
just
partial
went
recapture,
down.
doctor?
so you push the wire a little bit.
We,
system.
no, actually,
Okay.
we put the wire. I pushed the system in order
Yeah.
to make it orthogonal. Orthogonal in the sense that we are always taking care of the virtual buzzer ring, and I see it because I see the 3 markers. So what I've done, I pushed gently on the system in order to have it at 90 degrees to the virtual buzzer ring. So I think we are in a very stable situation, and I have to say that I would be happy to deploy. Nedi, do you agree with this?
Yes, if you want, you can check in task overlap.
Let's check in task overlap. That's a good point. This is a good point. We have all the time, as you can see, pressure is perfect, also because our anesthesiologist is helping. So we got time. Let's have a look. This is cast overlap or the modified cast overlap. That's the, let's say, conventional. Okay? Can I take an angel? Okay. This is good. This is good. So, can we have a
Are you happy,
projection of
everyone
the
here? Are you happy?
Yes, just advance the
okay.
wire to stabilize
Yeah.
it from below. It does not migrate down once you release the system.
The panelists
I
are
mean,
happy with the position.
You can do a final release.
I think we are.
But do you want to pace?
Well, that's a good question. I think, pacing is a good option in this case, because obviously these tortuosities may ask us to pay a price. So I would say that at some point when we are all happy about the final deployment, I would ask Elisabetta to give us 120, not too much, 120, just to make it regular. And so Nedi will slowly release the last 20%. Do you agree with this plan?
Yep.
Agree.
Yeah.
Stop. Okay. So, which projection? So let's go back in the projection where the parallax is
The left one.
correct. Okay. Okay. Let's go in 24 left, 25 caudal. I think it's okay. So what I will do, I will just, okay. As you can see, I'm not doing much, to be honest with you, because the delivery system is really stable. 120, and then Nedi will slowly deploy. Okay, so store, please. Go to 100, and then go to 80, okay? So this is something that we do. Now, we're not sure that it's really needed, but typically when we are pacing, we don't really take off the pacing. We just slow down, and then we take off the pacing. But, you know, to be honest with you, I mean, it's a matter of practice. It's a matter of practice. But I want to show you how important it is to make sure that all the 3 tabs are released. Okay, let me stress this point, because obviously it's up to us to make sure that this delivery system is free. I can tell you this, and you can see it is. Nevertheless, this is absolutely crucial. What I will do, well, Nettie will show you. So now she will work on the wire and the nose cone. The nose cone can come back, no problem. This is not a problem, because she will push a little bit the wire. The wire will go back into the LV, and then the delivery system will be recovered. So please, Nettie, stop a little. So let's go in 80 straight.
Nicely done.
Okay. So now we will recover. Just, okay, Nettie, please. Put the prosthesis in. All right. I have to say, let's say, as a matter of fact, we tend to evaluate the pressure before and after. And I'm talking about the gradients. I'm talking about the diastolic pressure in the LV and the aorta. So we are going to do that before making any angio. And then we'll do the angio, and we evaluate whether we need or not to do the post-dilatation. I have to say that according to the, let's say, aortic pressure that I see, probably there's no need. Nevertheless, we will check, of course. But I would like to, underline how stable was the implantation. And to be honest, this is actually what we were expecting. Please, Nettie, go ahead here. And as you've seen, there was just a few seconds of drop pressure because the delivery system was really non-coaxial. But after placing this delivery system in a coaxial position, the recovery of the pressure was instantaneous. So I have to say very stable. Let's see now the outcome, of course, but I'm, let's say, optimistic, if I can say that.
Fantastic
The
implant.
height,
I just had a question.
the
Is that what are
height
you
of the implantation, sorry?
What are you pacing in the RV? What is that in the RV? Is that a wire?
We are, okay, let me explain this. This is a very cheap way, let me tell you, because we place a 0.35 wire into the RV, and then we leave a Jackin's left diagnostic catheter for French. So the venous access is a 4 French, okay? In other words, in cases where pacing is unstable because the wire is moving, or maybe you have, a huge tricuspid regurgitation, a hugely dilated RV, we need to use a different way. And I mean, let's say, temporary pacing. But this way, it's pretty stable, and also it requires, as I said, a 4 French. This way, we basically minimize the risk of having complication related to the pacing. In terms of, let's say, cost effectiveness is absolutely fine for us, at least in Italy. And honestly, if something goes wrong, we already have a venous central access. That's the main thing, right? Obviously, we hope that we are not going to use it. Nevertheless, in the case we need, we already have. So it's a kind of a parachute, if you see what I mean. Please zero the 2 lines. Okay, I was actually, discussing with you, and Nettie was basically doing the job, so I thank you. And no, but it's okay. And we do that all the time, so it's not definitely not the first time that we work together. So there's no gradient, and that's encouraging. The 2 diastolic pressures are absolutely separated, so I'm still optimistic, if you don't mind me to be there. So, do you mind if I have an angel?
Yes, let's do it. If you don't mind, so we can go ahead, because we have only 2 minutes now.
Oh, sorry. Okay, ready, steady, go. That's kind of fantastic result. Thank you, guys.
Excellent,
So,
excellent. Great.
This is really what we were expecting. And, you know, if you have 1 minute, I guess, I need to thank all the team because obviously you don't know, you know that, but let me express my gratitude to all the team here because no one can do this job alone. And thanks to the nurses, technicians, the ABO support, the anesthesiologists, thank you, Arianna. Most of all, thank you, Nedi, because this result is absolutely fantastic. So thank you very much. And now we take care of the access, okay?
Dr. Testa has a difficult case, difficult anatomy, horizontal aorta, and you made it sound very easy case. So excellent job.
That was the-
Thank you very much.
the
Thank
idea.
you.
Thank you.
You're very welcome. Enjoy the Congress. Thank you very much.
Okay,
See
great.
you next time.
Thank you. Ciao.
Thank you.
And also,
Ciao.
I'd like to thank my dear panelists for a great discussion. Thank you all for your attention. Thanks.
Thank you.
Thank you so much.